This is a relatively quick PowerPoint on heart failure. Okay, heart failure, what is it? Well, to put it in a nutshell, it's when the heart's not pumping like it should. Okay, there could be a variety of reasons. It could be because of an MI, hypertension, dysrhythmias, infections, sleep apnea, heart valve abnormalities, or other things that have overloaded the heart. Maybe we did it. Okay, maybe we gave the patient too much fluid. A PE, severe anemia, hyperthyroidism, etc. Okay, and you can move on and on. Excessive, believe it or not, excessive exercise. Okay, maybe using illicit medications. I shouldn't say medications, illicit drugs. Okay, all kinds of things could cause failure. Okay, what is heart failure? It is when the right or left side of the heart does not work correctly, is unable to pump like it should, or both sides are unable to work correctly. Usually the left side's affected first. And the only reason that is because it is the biggest one. It's the left ventricle is what is the powerhouse of the heart. Remember, it has to go through all that afterload, so it has to push against that afterload. Therefore, it is the first one that usually, I want to say usually, fails first. Heart failure occurs on either side of the heart when it can't keep up the blood flow. So generally, when we're talking about heart failure, we're talking about the blood is not able to get out into the system, okay, or it backs up. I like to think of heart failure when you're talking about left or right sided is like a clog in your plumbing. If there is a clog in your left ventricle, then it's going to back up. If there's a clog in your right ventricle, it's going to back up. But we'll talk a little bit about that. As a result, cardiac output falls, leading to decreased tissue perfusion. So that is where people get shortness of breath. Maybe their color is off. They're not able to get the oxygen where it needs to go because of the fact that the heart is failing. Okay, classifications. There's a systolic versus diastolic. Systolic is when ventricle unable to contract effectively and it's not able to eject that blood into the rest of the body. It can't go through that afterload. Okay, diastolic happens when it can't really relax. Okay, so it doesn't allow the filling to occur. Okay, so that really has a lot to do with preload. So the normal filling is unable to occur. So the ventricles are unable to fill, and therefore it's going to cause a decrease in cardiac output. Left side versus right sided, and acute versus chronic. Acute is something that we've caused a lot of times. I don't want to say all the time, but we can cause that. With septic patients, we give them up to 4,000 milliliters of fluid. To keep them going. So we could easily put them into fluid overload and CHF. Any patient that is hemorrhaging, easily we're able to put them into fluid overload. Okay, there's the 4 stages of congestive heart failure. Stage 1, breathlessness or tiredness with a brisk walk or taking a flight of stairs, right? I mean, really, you can pawn that off on just not being physically fit, right? Okay, number 2, stage 2 is comfortable when resting, but whenever they get breathlessness when they're walking a block or taking the stairs, okay, the heart races. Stage 3, palpitation or tiredness with simple tasks, like getting up from the sofa, going to the bathroom, going to the kitchen, anything like that. They just get tired. They feel their heart racing. And then stage 4, heart and breath goes faster even at rest. They're very tired when they're sitting. They have anxiety, okay, and palpitations almost all the time because their heart is just not able to pump like it should. The atrium's pumping, but the ventricles aren't able to keep up. So eventually they're just going to say, I'm out of here and quit. Okay, left versus right. When we're talking about left versus right, think of the clog in your drain. If you have a clog outside your house, well, that means no water is going to get into your house, right? It's going to maybe flood your backyard or wherever that clog is. If you're talking about a clog in your kitchen drain, okay, that means all the fluid, all the water that you're pouring down the sink is going to come back out into that kitchen drain. So that being said, think about your left side. If there is a clog in your left ventricle, okay, because, and don't think I'm thinking like a clog like an emboli, it's just not able to move. The blood's not able to move because the heart is failing. Think about where that blood is going to back up into. It's going to back up into the lungs, right? That's why when left-sided failure, you're going to hear crackles and wheezes. They're going to be dyspneic, okay? They might have a cough. They're going to feel like crap. They're going to feel fatigued. They're not going to be able to do anything because their oxygen is not getting to the parts of the body it needs to. They're going to have orthopnea or paroxysmal nocturnal dyspnea, okay, which means that they're not able to lay flat. So orthopnea means they're not able to lay flat. If they lay flat, they feel like they're drowning. They have to sit up to be able to sleep. Cyanosis and an S3 gallop. The S3 gallop is a sound in the heart that says, hey, it's overload, okay? Now let's go to the right side. Now think where your right side is and where the blood is coming from the right side. It's coming from all aspects of the body, right? Both from your head and down to your peripheral, okay? So jugular vein distension. Remember, there's a clog there, or there's let's just say a blockage. A blockage is backing up into your jugular vein. Abdominal enlargement, okay? There's nowhere for that blood to go, so it's going to go bigger. It's going to go back and settle into your stomach. Dependent edema, that's when we're looking for that pitting edema in your legs, in your arms. Weight gain, decreased urinary output. The reason what's happening with your urinary output is that the kidneys aren't being perfused. There's not enough force behind that blood, okay, to perfuse the kidneys. Therefore, your urine is going to be decreased. Okay, so that means that all that blood that's not being pumped is retaining all that fluid. Okay, and right upper quadrant pain and liver engorgement, the same thing. Okay, it's because there's nowhere for that blood to go, so it's backing up. Okay, um, so you will have to know the difference between left and right, but also realize that some of them, sometimes you'll have signs and symptoms of both. Okay. Okay, complications, congestive hepatomegaly, that's an impaired liver function because the liver is so engorged it's not able to get the blood out. Okay, splenomegaly, which means your spleen is also enlarged. Ascites. Now this is an interesting concept because ascites could be one of two reasons. Ascites could be because of the fact that there's nowhere for that fluid to go, so it's going to go third space. So when we're talking about fluid in the cells, right? Well, there's so much fluid in the cells that actually the fluid starts going outside the cells. Okay, so that all that fluid that you should be excreting in your kidneys is actually going to go on the outside of the cells. Now that's one part of having ascites. The other part of having ascites is albumin is a wonderful, wonderful I don't want to say medication. It's not a hormone, but it's not really coming to me what it is. Um, Albumin is delivered by the liver, and what it does is it helps put um, fluid back in the cells. Okay, so when you have a fluid overload, your liver's not able to work like it should. The albumin's not going to be there. Plus the fact that you have too much volume, so even that is going to decrease their level of albumin. So the lack of albumin is also going to cause those cells to third space. When we talk about ascites, we're talking about enlargement of the abdomen. The abdomen is grossly enlarged. Sometimes we're able to go in and do a paracentesis and take that fluid off. Patients that have liver damage, they have sclerosis or hepatitis, a lot of times they'll have ascites and will tap, get that fluid off. With When we're talking about CHF though, the liver is not the problem. The problem is the fact that the patient is over full with fluid. So what the best thing we can do is get that heart working, and that heart working better will get that fluid also off also. We can also do dysrhythmias. These folks that are in heart failure have a good chance. I don't want to say good chance, but they're more apt to go into a um, fatal dysrhythmia. They go to VTAC and VFib. That ventricle is working so hard to get that blood through, and it's not able to go. Eventually, it's just going to quit. It can't do it anymore. Okay, that's when it will go into a VTAC or VFib rhythm. That's why people with less than a 25 ejection fraction get a a life vest, or they get an ICD. Okay, so that if that does happen, we can shock that heart hopefully back to life. Left ventricular thrombosis. Well, let's face it, the blood's not moving from that left ventricle. The left ventricle is pretty darn large. And when you don't have blood moving, what are you going to have? You're going to have a chance for the blood um, to have stasis, and also um, it has more coagulability. Pleural effusion, that is when there's really nowhere else for the fluid to go, so it'll go into pleural effusions in the lungs. We'll talk a little bit more about that in respiratory. Acute pulmonary edema. The way I think about acute pulmonary edema is picture yourself having a water balloon. Okay, that water balloon, and hold it by the what do you call it? The lip, the entranceway, the place where you blow. Hold it up like that. You notice that all the water goes to the bottom of the balloon, right? Now place that balloon onto a table, and what happens? It flattens out, right? Well, with acute pulmonary edema, that's what we can do. Uh, what can happen? The lungs get all filled up. Okay, it gets so filled up the patient is unable to breathe. Okay, we got to get those lungs. We have to get the fluid off the lungs. Now, what we call flash pulmonary edema is somebody has a lot of fluid in their lungs, they have crackles, and say we take them downstairs to do an MRI, or maybe they went for a heart cath or something like that, and they lay flat. That the lungs are acting like that balloon whenever you put that water balloon onto a flat surface. That fluid's gonna cover the whole space of those lungs. That's flash pulmonary edema. Sometimes we have folks that are so um, that's a major problem for them because their heart is so bad. So if we do have to do an MRI or a cardiac cath or something, we'll intubate them first, and then we'll do the procedure because we want to protect that airway. Cardiogenic shock is also a problem, and that's when the heart basically goes into shock. And cardiogenic shock usually happens about a week after onset. Um, so we really have to watch out for that also. Okay, diagnostics. BMP. BMP is brain nucleatic peptide. And what I understand is whenever they first discovered it, they discovered it in rats, in their brains. Don't know why. That's what rumor has it though. For us, what BMP is the stretching. So your heart is stretched. When your heart is stretched because of over volume, okay, fluid overload, then it throws out these BMPs, these peptides. That's what we measure to see if somebody's in heart failure. Okay, anything over 100 is considered congestive heart failure. Okay, and we usually call it exasperation. Now, people's BMP, if they are in heart failure, will be elevated all the time. Okay, so it might be 111 or 112. What we really have to do is look at their baseline, because we can have a patient that has a 5,000 BMP and they have skinny ankles. they really have no signs or symptoms that they are in congestive heart failure, but yet they are. Okay, they're having a hard time breathing. On the same aspect, you might have somebody that is blown up like a tick and their BMP is only 171. Okay, so it's not, so the level of your BMP is not indicative of how bad you are, if that makes any sense. BUN creatinine, well, your kidneys aren't being perfused. So what happens? Your BUN and creatinine will be elevated. Okay, almost like if they're being dehydrated. Okay, a UA, we will do a UA. A liver function panel, let's see what's going on with that liver, if it's the urositis is due because of liver or because of your heart. And a thyroid panel, because we have to throw that in there. Okay, we're going to do a chest x-ray. A chest x-ray will show if a patient comes in and they have crackles and they're dyspneic, we're going to be able to do a chest x-ray to see the difference between pneumonia and CHF. Okay, echocardiogram, we're going to see if there's any damage to the vessels, to the structures of the heart, to see if they're regurgitating, what's causing the heart not to function well. We can do some nuclear tests to show the perfusion, and we can also do hemodynamic monitoring. Okay, medications. Diuretics. When we're talking about CHF, we're not talking about, hydrochlorothiazide. We're talking about Lasix, okay? Furosemide or Bumex, okay? A couple years ago, we were low on there was a national shortage on furosemide, so we gave Bumex. But diuretics, okay? Remember with your diuretics, when you're talking about Lasix, we have to be careful of the potassium and blood pressure, okay, before we give it. ACE inhibitors and ARBs we can also give to help vasodilate and get that fluid off the heart and help the heart. It doesn't help the heart pump, but it helps get the fluid off. Okay, beta blockers. We have to be careful with the beta blockers though. If a patient is in CHF and they are having a hard time breathing, okay, they have crackles throughout. Beta blocker, I'm sorry, the mini on. A beta blocker could also exasperate. Remember with beta blockers, what they do is they decrease the afterload decrease the afterload of the heart, right? So that pressure that the heart has to go against. But on the same aspect, it lowers the heart rate. The one thing we don't really want to do at this point in time is lower that heart rate so much that it's not going to be effective. Okay, so we have to be very careful. If they have uncompensated CHF, then beta blockers are probably not the way to go. And I guess I thought diuretics is important because I threw it on there again. Maybe I was thinking that diuretics could also mean spironolactone. Spironolactone is the potassium sparing diuretic. And a lot of times when you're looking at patients that are in stage 3 and stage 4 of heart failure, you'll see that they will have both of those. Positive inotropic medications. When we're talking about positive inotropic medications, the one thing that comes to mind is digoxin. Remember with digoxin, we have to be careful of the potassium. Too low of a potassium, and we're even talking 3.4, 3.3, could cause a patient to go into digitoxicity. So if you remember about digitoxicity, we make sure that the heart rate is above 60 and that the potassium is between 3.5 and 5. Okay. Remember also the digitoxicity can also cause some signs and symptoms of digitoxicity is halos, yellow halos, nausea, vomiting, okay, diarrhea are all telltale signs of digitoxicity along with bradycardic. Direct vasodilators like hydralazine, Presaline can also help get the fluid off the heart. Antidysrhythmics, so amiodarone. I noticed on the discussion board a lot of people were talking about amiodarone. Amiodarone is an antidysrhythmic, but don't count out some of those other ones like calcium channel blocker or beta blocker. Core egg we can use also. Okay, don't count out those because even though they're beta blockers and even though they're calcium channel blockers, we can also use them as an antidysrhythmic medication and anticoagulants. Remember, one of the complications of heart failure is the left ventricular embolus. Okay, so we like to put our folks on anticoagulants so that we don't have to worry about that embolus. Okay, other invasive treatments. There's IABP, which is an intra-aortic balloon pump. It basically does the work of the left ventricle. Okay. Then we have the LVAD, which is a left ventricular assisted device. With LVAD, I have a video about the LVAD, but it does the work of the left ventricle, but it's for long term. We're talking about a balloon pump. We're talking about a short amount of time, a couple of days, okay, until we can get treatment. An LVAD is good for patients that possibly could not get a cardiac transplant, okay? Or maybe they're too young for a cardiac transplant. You know, transplants are only good for like 10 to 15 years, okay, usually. So an LVAD might be a good option for a younger person, 20, 25-year-old person until they can get that transplant. Cardiac transplantation, of course, we can do that. Hearts, let's face it, are a little hard to come by because there's only one per person. But we have to also worry about post-op rejection and infection. Okay, heart failure management, sodium restricted diet. Be careful. Ask the patients what they think about a sodium restricted diet. What does that entail? Well, did you ever look at the can of a diet soda? There is a lot of sodium in Diet Coke. Okay. Any kind of canned foods, canned vegetables have soda. Your deli meats have sodium. Did I say soda or sodium? Canned vegetables has sodium, not soda. And your deli meats have sodium. Okay. Olives, anything canned. So it's hard, but talk to your patients about the low sodium diet. Okay. Fluid restrictions. I think this would be really hard. Okay. Some folks are on maybe a 1300, trying to think, 1300 milliliter diet. Yeah. 13 milliliter, 13,000 milliliter water restriction. Okay, so that's why a lot of times when these folks are on water restrictions, we'll give them ice cubes. Gives them something in their mouth a little bit longer than just a drink of water. Increasing activity and tolerance slowly, and then progress into an exercise program. It's the same thing with cardiac rehab that we talked about with the other with our cardiac patients. We want to get them up and moving, so we get them in contact with cardiac rehab. They'll come see them while they're in the hospital, and then they'll keep touch with them when they're outside the hospital. Patient education is key. Monitoring weight. Got to make sure that they weigh themselves every day, and make sure it's in the morning, and make sure it's with the same clothes or naked. Okay. It was funny. I had a quiz the one time, and it was they were working together. I let them do groups of like 4 or something. They were working together, and this one student talked everybody else into the answer. The question was, when was a good time for the patient to what was a good time for the patient to weigh themselves? And they talked the other students into nighttime. It's not nighttime. You don't talk about all the food that you eat and everything like that. It's in the morning with the same clothes or naked. If they have a weight gain of over 2 pounds a day, or 5 pounds a week, they are to go see their doctor. Also identifying risk factors and making modifications is a factor. Okay, what would cause them to possibly have CHF? Exasperation. Could it be that they like going to Chinese restaurants, to the buffets? Okay, maybe that's not such a great idea with all the sodium that's on those in Chinese food. But making lifestyle modifications, and it might be just one thing here, one thing there. We don't want to go overboard, because if we go overboard and say don't do this, 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 and this, guess what? They're going to do it. Okay. Education on medications. When should they take the Lasix? Should they take it in the morning or should they take it at night? Okay. When should they monitor their pulse? How do they monitor their pulse? When should they not take the medication? If it's 60, should they still take the medication? Okay, we have to really think about everything about their medications. We're kind of used to it because we are, trained. These folks aren't trained on their medications, so don't assume they know everything. And again, cardiac rehab. Get in touch with those folks so they are able to do an exercise program with them. Okay, pulmonary edema. I talked about pulmonary edema, abnormal accumulation of fluid in the interstitial tissue and alveoli of the lungs. Cardiac causes, MI, acute heart failure, valvular disease, also acute respiratory distress syndrome, ARDS, which is what a lot of those folks with coronavirus are going through. And that's what's unfortunately causing their deaths, is because they go into ARDS. Trauma, sepsis, drug overdose, and neurological injury. Medical emergency. Pulmonary edema is a medical emergency. Onset or gradual. Symptoms. Think about it. They can't breathe. So they're going to be tachypneic, tachycardic. They're going to have labor. They might actually have pink frothy sputum. And the reason is because the fluid in their lungs has nowhere else to go. So it's going to break some of those capillaries. Okay? And cause that pink frothy sputum. What else? Diaphoresis, hypoxemia. They're going to be restless, anxious. Okay? They're going to feel that impending doom. What are we going to do? Well, we could get ABGs. We could do some hemodynamic monitoring. Oxygen. When we're talking oxygen with a patient that's in full with pulmonary edema, we're not talking about 4 liters, 2 liters. We're talking 15 liters non-rebreather. Okay. Think about it. It has all that water in their lungs. We have to get enough oxygen to permeate that water, and so that the blood can do an uptake on the oxygen. Morphine. Why morphine? Well, it's a vasodilator, so it can help get that fluid off the lungs. Loop diuretics. This is not a time to fool around and just give like a 20 of Lasix. We're talking 60, 80 milligrams IV push of Lasix. Okay. With that being said, you might want to throw Foley in there also to help your patient. One thing you don't want to do is have this patient have to roll side to side to get on a bedpan, and they're not going to be able to get up. Vasodilators like nitro or nipride can be IV to help vasodilate and get that fluid off that patient. And inotropics, dopamine, dobutamine, though cautiously with dobutamine, especially with heart failure, and possible digoxin. Get that heart working better, contracting better. Digoxin does help. It slows down the heart rate, but what it does is it makes the heart contract better. Okay, and that's why it slows down the heart rate. So we want to get that the heart pumping better to get that fluid off the lungs. Okay, ensure patient airway, suction as needed. High Fowlers, beach chair. So, those beds don't go as high as sometimes we want. Throw some pillows behind that patient so that their head is up as high as we can. Okay, their back is up. Continuous monitoring. It's not a time to sit there, throw them on a pulse ox and walk and go have lunch. Accurate eyes and nose. We want to know how much fluid's coming off that patient and how much we're putting on. Restrict fluids if needed, and emotional support. This is not the time to sit there and say, we will save you, everything will be okay, because sometimes it's not. The best thing you can do is tell them that we're doing the best we can to get them through this situation. Okay? Okay, cardiomyopathy. Did anybody ever watch Beaches, the original Beaches, with Bette Midler and I don't know the other chick's name. Anyway, what Beaches is about is a lady that got a virus in her lungs, or in her heart, sorry, in her heart, and that's how she explained it. She got a cold in her heart. Anyway, it's a good video, and if you have time, rent it. It's a chick flick. It's a good one. It's a good chick flick. Like on the same lines of Steel Magnolias. Okay, anyway, there's three different types. There's dilated, hypertrophic, and restrictive. Okay, normal is your top, let me see, is your top left one. Okay, looks like a good heart. Your dilated means that your ventricles and your atria are dilated. Remember, if they dilate too much, it's going to make it hard for them to do a forceful contraction. If you see hypertrophic, look at how thick those walls are. Okay, they have too much muscle, too much mass that they're unable to. The heart's unable to pump very well at all. And then you have restrictive. And what happens is these are just, this is thick and stiff, and this is just stiff. When it's stiff like this, what happens is that it's not able to contract also. Okay? So, dilated cardiomyopathy, idiopathic, maybe secondary to some viral infections, but it can also be toxins, alcohol. Frequently in middle-aged males with higher incidence in African Americans, and the heart chambers are dilated, impaired ventricle contraction, and can lead to decreased ejection fraction on both left side of heart failure. Then we have signs and symptoms. Well, guess what? It's all heart failure. And that's what you're going to see. All heart failure symptoms. Okay? You're going to see some dysrhythmias. You could have some thrombi. Okay? Unfortunately, with dilated, it's poor prognosis. Okay? The only way to really fix it is for a heart transplant. Okay? Hypertrophic cardiomyopathy. A lot of times these are genetic by 50%, but is also known as idiopathic hypertrophic subaortic stenosis. Okay, a lot of these cases, what happens is that you hear about those young athletes that are working out on the football field or basketball court, and then they collapse. A lot of times it's because of this, the hypertrophic cardiomyopathy. Signs and symptoms. Well, guess what? It looks like exactly like our regular, regular heart failure. That's what it is. It's heart failure, okay? And we treat it like heart failure. All these myopathies, we treat it like heart failure because, well, that's what it is. And there's really no other way to treat it. It's heart failure. Any way you slice it, it is heart failure. So we're talking about Lasix and digoxin, okay? Restricted potassium. Restricted fluids. And then we have cardiomyopathy. This is the least one that we see. It's the rigid ventricular walls. Okay, the ejection fraction is not really is unaffected, but they have heart failure and they have poor perfusion. And that is the end of heart failure.